Well, it's my pleasure to welcome everyone and to introduce Dr. Ben Sabayan, who I've had the pleasure of working with when he was a vascular neurology fellow here at the Mass General Brigham program not very long ago. But he came to us as a fellow with one of the most distinguished CVs of any fellow we've ever seen. He's has a PhD in clinical neuroscience from the University of Leiden in the Netherlands, where he did extensive epidemiological work and did his residency at Northwestern in Chicago before moving to Minneapolis and becoming the director of Regents Hospital Health Partners Comprehensive Stroke Center and a member there of the Center for Memory and Aging. He's had for quite a long time a deep interest in brain health, primary prevention, and that's been driven by his distinguished work over the years in understanding the epidemiology both of cognitive decline and in particular vascular cognitive impairment. And you may have noticed his opinion piece review on brain health and primary care of the brain in neurology about 6 months ago, if I'm not mistaken. And so it's my great privilege to turn the floor over to Dr. Sabayan. The title of his talk today will be Preventive Neurology and Brain Health.
Thank you so much. Good morning, everyone. It's such a great pleasure to join you today. It's such a great pleasure to work with you, Dr. Roseanne, and the rest of the team. I'm really appreciative of the opportunity. Today I'm going to talk about preventive neurology and brain health. As this audience is very familiar, brain health is a very broad topic, and it can be approached from different perspectives. Today, what I'm going to do, I'm going to approach the topic from aging and brain aging standpoint, and then we're going to talk about different trajectories for brain health and see what can we do to preserve brain health and be more proactive on that. And at the end, I will be very delighted to share some thoughts and hear some feedback on what could be the future steps. So I would like to start the presentation with sharing this slide, which basically reflects that the longevity revolution is going on. So this graph shows distribution of the population in terms of life expectancy through the time. And as you can see here, in 1950s, we had very triangle shape distribution, and less than 5% of the population had life expectancy of 65 and plus. And 2020, this was around 10%. It's expected that by 2100, more than 20% of the population would reach to that level of life expectancy. There might be some hit from COVID, but the trend is going to stay there. That tells us that we're going to have a wave of grays. It's already started, but we're going to have a little more prominent situation. So this is a graph coming from a very solid study from the Rotterdam study that they included more than 12,000 people in their population-based study, and they looked at the lifetime risk of neurological disorder. It's very interesting to see that in these populations, which started around age of 45, only 5% of the population by age of 65 had a lifetime risk of neurological disorder, while this number reached to 30% at age of 85, 6 times expansion over 2 decades. And in this same study, they did modeling and to see what can we do to decrease that burden of lifetime risk of neurological disorder. And what they observed was that if there will be effective preventive interventions that can delay 1 to 3 years of onset of neurological disorder, you would have 20 to 50% reduction in the lifetime risk for neurological disorder, which means a huge societal and economical impact for the society. So it's difficult to ignore the fact that age is really a factor here. And with that, I would like to kind of share some thoughts on definitions, what could be the driving force of aging and brain aging. In simple terms, and maybe a comprehensive term, aging is accumulation of a damage in a biological system in the absence of or failure of healing mechanisms. So that's the aging. And when we are talking about brain aging, we are talking about constellation of morphological and physiological alteration in the brain, secondary to accumulation of the damage that would ultimately leads to impairment in motor, cognitive, and social skills, as we can see in some of our celebrities. So with that definitions in mind, we can approach brain health. So when we are talking about brain health, the concept of brain health put emphasis on protecting the brain to avoid reaching to the critical point when the disease is overt, clinical symptoms are present, and the change has happened and a progression is irreversible. But it's also important to keep in mind when we are talking about brain health, we are talking about a range. We are not just talking about avoiding having a brain disease. We are talking about a wide range that within that range, the brain health would be in such a shape that you would have preservation of motor function, sensory skills, cognitive skills, and that will bring the quality of life and well-being to individuals. So that's the working hypothesis, working concept for brain health. Let me summarize these different concepts in this graph. On the y-axis, on the x-axis, we have age, young adulthood all the way to the late life, chronological age. And the y-axis, we have different dimensions, like pathophysiological processes going on through our aging and different brain health trajectories. Different lines of studies showing that what would happen is that we start building up exposure to risk factors in young adulthood. But our biological system, our brain is ready to activate compensatory mechanisms to handle those risk factors. At some point, we would go to different trajectories. One trajectory would be that addressing those risk factors and pathologies and damages and having functional preservation, which will be a kind of delayed brain aging, which would deviate us from reaching to that point that will be threshold for brain disease. But on the other side, the trajectory with the compensation trajectory, when you pass the threshold for manifestation of the diseases, and then you would have accelerated brain aging. As you appreciate here, there are different driving forces and interacting forces for brain aging and brain health. One key factor that I just mentioned is the risk factor exposure. And that comes with the importance of not just being exposed, but also what was the dose, what was the duration, what was the frequency. So risk factor exposure was one force. But then the other force that some of you might be familiar and is mainly coming from the cognitive field is that how much resistance do we have in our biological system to address those risk exposures? And basically that resistance tells us that how much our biological system is ready to avoid and address adversity and avoid establishing pathology. It's basically the act of repair and maintenance. But then the other force will be resilience. And resilience means that once the pathology is established and kind of resistance kind of exhausted, how can you deal with established pathology and maintain function despite pathology? So these are the main three forces that would drive brain health. And let me share with you one example. This is like a common case that I see in vascular neurology clinic. 78 years old gentleman comes with history of hypertension, diabetes, smoking, prior TIAs, and coming with this MRI, which shows at least moderate degrees of preventricular and subcortical white matter lesions. And as you go through the scan, you will see also some lacunar informs. When we ask the patient, how are you doing? Patient lives still independently, can manage the finances. But then he would report to you that, doc, I'm much slower in terms of my gait and cognitive function. Still, I can manage everything, but I'm much slower as compared to a decade ago. In this example, we have this life course exposure to risk factors. The biological system, the resistance was there at some point, but now you can see that there's signs of impaired brain structural integrity and vulnerable brain, which is a reflection of exhausted resistance. but then you would have relatively preserved function. It means that despite the pathology, we have resilience. So this kind of depicts these driving forces for brain health. But then the key question is that having those driving forces in mind, what can we do to maintain brain health? And I would like to focus specifically on those three forces. Generally, when we are talking about risk exposure, we need to alter the trajectory of risk exposure. And that's a life course work. That's not just a snapshot work. When we are talking about resistance, means that we need to do things to boost healthy habits and behavior to promote the act of repair, the mechanism of the repair. And at the end, we need to kind of stratify people in terms of their resilience situation. And maybe we should go all the way back and do early life interventions that I'm going to go over in the coming slides. For risk exposure, as we know that there are like so many risk exposures, and for our clinic and for our flow of work, we came up with this ABC framework that I wanted to share with you. So the ABC framework is a kind of framework that we want to make sure that we are comprehensive and we are thorough in terms of addressing all the risk factors. It starts with A, awareness. I cannot emphasize enough that how important it is to be aware of your status of brain health and what can we do about that. Simple things like avoiding trauma to the brain, all the way going to risk factors and your cognitive function. And B is blood pressure, that I'm going to actually go over a little further. Probably one of the most important and robust risk factors for brain health. And C would be comorbidities. We tend to ignore that what happens in our body would affect our brain. And I'm going to also talk about heart conditions as such. But comorbidities are not just about the disease, but also the medications, for example, anticholinergic medication. When it comes to these drugs, the smoking environment, we have more and more evidence coming that, for example, air pollution. I mean, a couple of days ago, there was like this piece in JAMA on environmental factors and brain health. F will be food and nutrition, glycemic, hyperlipidemia, and at the end, last but not least, inactivity, isolation, and insomnia. So when I'm sharing this ABC framework, I just want to emphasize that we are doing this ABC framework checklist to address established risk factors. And what we are interested in is not just measuring one time, is looking at the trajectory over time, which will be more important than one-time measure. So I'm sure that everyone here has heard about Simple 7, Life Simple 7. This is something that American Heart Association has a lot of emphasis on it. And we have even this piece in a stroke on the primary care of role of primary care in Simple 7. I wanted to take the moment and share some thoughts with you. So obviously Simple 7 was an interesting concept, was really advocating for so many primary prevention, but it comes with some caveat. When you are labeling these as Simple 7, and if a subject cannot achieve those simple stuff, that has a meaning, that has an implication. There are different lines of studies showing that actually for those Simple 7, there's really high risk of relapse and failure to achieve those Simple 7. And if you would leave the patient alone to address, to handle those risk factors, it frequently leads to failure or incomplete achievement. And what we need to keep in mind is that this is really beyond just lifestyle modification, right? It's about the structure of healthcare system and society. So in this piece, in a stroke, it was suggested that maybe primary care physicians are best poised to be in that role. And I agree with that. They play a very important role. But we need to also keep in mind that achieving brain health through a 20 or 30 minutes visit with all this complexity, it might be challenging and it might undermine the importance of the situation. As I mentioned, hypertension is probably one of the most established risk factors for brain health. And we always talk about it and we always talk about the importance of it. But let's just focus on hypertension as one of the simple risk factors in that Simple 7. and see really what it takes to kind of address that for a patient. For example, when we talk about brain health and hypertension, are we always talking about high is always bad? At what point how high or low matters? Is it about single measure, or we need to have multiple or cumulative blood pressure measures? Is it about average, or is it about variability? And what outcomes matter? So these all reflecting that we need to think as complex as the brain it is, not necessarily just looking at simple measures. We had the pleasure to work on this concept of blood pressure, hypertension, and cognitive function and brain health for years. I kept losing the track of the evidence. And thank God this meta-analysis and systematic review came out with more than 200 prospective studies. It's nicely summarizing the evidence, and it shows that you need to look at midlife, late life. What we were able to show that is not just a high blood pressure, but also low diastolic blood pressure in late life, and blood pressure variability are also important factors when it comes to hypertension and health, brain health. So I just wanted to kind of show this to show you that it really goes to a lot of complexity to even talk about one single risk factors. For example, in this case, we know that the effect estimate of high blood pressure in terms of adverse brain outcomes attenuates with advanced age. There's reverse causation. There's a concept of cumulative exposure. Think about like pack here for smoking as compared just to one single or multiple measurements. And what I wanted to kind of share with you here is that it really takes an expertise to interpret the data, to share with the patient and see what should be the next step. And that means that we need to have brain health experts, not necessarily just looking at one single measure. I think everyone is familiar with this concept of intensive blood pressure control, and this is like a sprint mind study that everyone is familiar with it. This is probably one of the few trials that showed benefit of doing something to prevent risk of dementia and cognitive impairment. This study did not really reach statistical significance for reducing risk of dementia over 3 years of intensive blood pressure control, but it showed that combined MCI and dementia risk will be decreased if you will be doing more intensive blood pressure control. But even in that study, there are nuances. I'm sure that you have seen a lot of follow-up studies coming out of a sprint mind study. For example, in this study, they showed that actually the total brain volume for in the intensive group was much more reduced as compared to the standard group, although hippocampus volume was kind of better in the intensive group. White matter lesion burden was decreased in the intensive group, and just a few weeks ago, they showed that intensive blood pressure reduction can lead to elevation of the cerebral blood flow, which is kind of counterintuitive because we were thinking about that maybe we are dehydrating the brain, and that's why we are seeing decreased total brain volume. So all in all, I just wanted to show you one example that how much thoughts and complexity goes to the relationship between even one of the ABC risk factors in relation to the brain health. Let's get back to our three forces. So we talked about risk exposure, we talked about ABC framework, and we talked about what can we do to kind of address that. But let's talk about what can we do to boost resistance of the brain. And reviewing the concept, it was the concept of how to address the adversity. I cannot emphasize enough that it's all about cardiovascular fitness. Cardiovascular fitness in different forms and formats is the one that would boost our resistance to handle the adversity. And when we're talking about cardiovascular fitness, I think the gateway to brain health is heart-brain axis. So if we will be able to focus on heart-brain axis, and then at the end, we will reach to the neurovascular unit as the key drivers for brain health. And on top of that, not just addressing the heart-brain axis integrity, but also to have preventive measures on top of prevention of the pathologies. So I mentioned about comorbidities. This is like a meta-analysis from 2007, years ago, showed that if you have high heart failure, you have much higher risk of having dementia later on. But what we were interested in the if there is a stress in the heart, not having heart failure, not having dementia, if there's a stress in the heart and there's a subtle decrease in the function, would it have also implication from brain health? That's what we did with very sensitive measure of cardiac MRI. We looked at the cardiac output and the stroke volume. We can forget about ejection fraction, which is not the best measure. And then we looked at different measures of brain structural integrity. It was very impressive to see that in those people who did not have heart failure, who had apparently had a good cardiac function, and they did not have any dementia or anything like that, even with that normal range, we could see that there's a very clear dose-response relationship between the level of cardiac output and stroke volume and brain structural volume, specifically gray matter volume. So you preserve the brain. And then what we saw was that we said, okay, we don't have this fancy cardiac MRI. Maybe we should go to simpler biomarkers, and we choose to use NT-proBNP. And again, in a population without any heart failure or advanced dementia, what we observed was that elevation of NT-proBNP level was associated with accelerated cognitive decline in 85 years old people. We looked at different cognitive domains, not just global, stroke test, letter digit, memory, delayed memory, executive function. They all show the same association. If there is a stress at the level of the heart, there is a cognitive decline. One thing that was very impressive for me was that we were looking at the older population. And the question for us was whether we are talking about buildup of risk factor exposure in midlife. How about if we would check that, and again, I'm talking about all normal range of NT-proBNP and BNP here, whether that has any relationship with the brain. And it was very impressive to see that elevation of these simple cardiac marker was significantly associated with the volume of temporal lobe and frontal lobe in those who were age 50 years and old, like with the average of age 50 years, which was very impressive. With the simple marker, we can see that in the middle of any other risk factors, there is a very clear relationship with what you have in terms of gray matter in the brain, especially for the temporal lobe. And then the next thing for us to see what does health of the heart-brain axis mean for the brain health was to see that whether accumulation of the pathologies in the heart-brain axis would have implication for the brain. So what we did, in the setting of ages registry study, what we did, we looked at carotid intermediate thickness and the NT-proBNP. And again, they are all within normal limits, clinical limits. And we split people in 4 groups, those who had both high carotid intermediate thickness and low, and then we looked at the association. And it was very interesting to see that if you have combination of these two in your heart-brain axis, you would have the highest rate of gray matter volume decline over time. As I mentioned, heart-brain axis is a gateway to brain health, and the key to brain health is a neurovascular unit. But let me say something here. Although we put emphasis on neurovascular unit, I wanted to share my thoughts on that. Is that what we learned over the last years and decades is that our brain doesn't like to look at it in a fragmented way. So whenever we focus on a specific pathway, a specific cell, a specific enzyme, a specific protein, we normally don't see the good results as we could see, for example, with amyloid. What I think is very important is that we need to look in a bigger picture and to think about upstream interventions rather than just focusing on astrocytes or endothelial cells. And that's why I think the importance of preventive neurology, preventive cognitive neurology comes to action. So we talk about the first 2 forces, and let's look at the third force, which was resilience. The resilience, the way that is very complex concept, right? It means that how you function despite the established pathology. The way that I would like to look at it is that when we are talking about resilience, we are talking about integrity of a network, how our network is preserve function and how we can prevent network collapse. So it's about network function. I would like to look at resilience as this, like as you can see in the y-axis, this graph. So we build up our network function or resilience through the time, and it goes all the way, and at some point it would collapse. But what would happen to resilience? So these are the adverse events, as you can see in gray bars, that would attack the integrity of our network to the point that at some point the network will collapse. What should we do to preserve resilience? The very first thing is that early life, the way that you would set the baseline resilience or the integrity of the network, that would really determine how you would act through the years or life course. And then the other thing would be decreasing the number of adverse events that you would have. And when you reach to your young adulthood, you need to push this curve of network connectivity upper. And by that I mean, for example, expanding your cognitive reserve with new language, with new skills. And that would all lead to pushing that dotted lines to the right side, which means that your network would not collapse early on despite all the pathologies. So basically, you would have this new scenario when you would set the bar higher at the beginning, and then you would decrease the number of adverse events, and then you will push the threshold later on. But what can we do to preserve the network or resilience? And that's a life course approach. The thing is that in neurology, we tend to look at the things down the road, but you need to really go back all the way to the early on. And for the life course approach, I think there are things on horizon. For example, genome editing for defective genes, early life experiences. In young adulthood, advancing cognitive reserves, as I mentioned, like language or other skills will be another one. Education at the population level is very important. Prenatal care is such an important thing. It might not be really much of an issue in developed countries, but in many parts of the world, that's really a stressful moment for the brain of many people. And then screening for those adverse life events. I mean, not just, for example, a cancer or any other processes, but also any other thing that would influence your cognitive ability will be very important. And at the end, when we reach to that point of the old age, to have risk stratification and have different types of care for those people. I want to take a pause here. I talked about those three forces. I wanted to take a pause and look back at what we are doing right now, because we talk about the brain health will be the preventing people to reach to the point that they will have brain disease. What are we doing now with the burden of neurological disorder? It is really impressive to see that over the last 3 decades or so, actually the absolute number of all neurological disorders, incidence, prevalence, mortality, and disability has increased, except encephalitis and meningitis. That tells us a lot, that there's a shift in terms of the burden of neurological disorder. Although we are much better with immediate management of the ICH, ischemic stroke, but now we are dealing with an increasing number of people who have established neurological disorder. And then the task for us will be, what can we do to prevent, to reach to that point? And that's what our piece comes, that we need to think about preventive neurology, which is a proactive approach as compared to the reactive approach. I think all of us would agree that neurological conditions share unique features. And those unique features are, one, most of them have long prodromal phase. It's good because we have time to intervene. Once they are established, they might be, most of them are chronic. And the other thing is that the cost is really huge for providing care for patients with neurological disorders. And we all agree that neurological disorder is probably one of the most disabling disorders ever, and especially with affecting quality of life. So having a historical perspective on the role of neurologists on our brain health community, I would say, is that we used to say, be proud of diagnose and adios. Everyone is familiar with it. In modern practice, what we are doing, we are trained in our medical school and everywhere, we are trained to be good at advocating for early and effective intervention, early diagnosis, and promote that. That's what we learn when you are doing rotations in ICU, in a stroke service, in the hospital, but not much on the preventive side. But what we need to do, really a game changer thing, would be that we need to put enough emphasis not just on the secondary prevention, but also on the primary prevention. And that's what Dr. Rosen kindly mentioned about our piece, that we are thinking about preventive neurology as a distinct expertise that would be more apply more proactive approach in early recognition of high-risk individuals before the disease manifests. And even if the disease manifests early on, I'm sure that wonderful work coming from MGH, Dr. BP, and the rest of the team, they're showing that even for those who have ischemic stroke, how bad are we doing with in terms of blood pressure management? So we need to kind of work on that to be able to decrease the burden of neurological disorder. And that needs a change in the mindset from brain disease to brain health. I think one of the most influential studies in the recent modern practice of medicine was this piece of paper that Dr. Rose wrote this paper named Sick Individuals and Sick Population. Unfortunately, the public health experts don't get as much attention, but I think this was one of the most influential studies. And basically, the concept that Dr. Rose suggested was that you can, if this is a distribution of the disease and risk in the population, you can always focus on that red part, which are high-risk people. For example, a patient had TIA, want to prevent a stroke, or a patient who had some transient neurological symptoms, you want to prevent future one. And then you would work on those who are like high-risk factors. So you can work on that small part of the population, and you can reduce the risk in this population. But your effect estimates would be much more profound if you would change the mean of the risk in the population. And instead of working on that small triangle, change the shift, provide a shift on the average risk in the population. And let me give you one example that might be kind of closer to your attention. This is about primary prevention of a stroke. This is a distribution curve for risk on having ischemic stroke. Based on the evidence that we have, if you'll be able to handle all these conventional risk factors for a stroke, you are able to, at the population, you are able to reduce 11% of the stroke incidence in the population. This is a really great number, you know, if you look at the large population. But how about if you would change and shift the mean of the population backwards? It's much more difficult, but what if you would be able to do that? And that's actually this green area. That means that you should push the risk backward. That would lead to 50% reduction in the incidence of a stroke. And then in a modeling that was published in this Lancet Public Health paper showed that these two don't have to be mutually exclusive. They can have multiplicative interactive effect. And if you will be able to do that, you can reduce the risk of stroke 90%, which is really a huge number. So I'm getting to the end of my presentation, and I wanted to kind of share some thoughts that we have in terms of what can we do. So we have here in Minnesota, we are, and then the health partner neuroscience, we are trying to establish brain health clinic, and we are trying to have some executive branches to that. So one already established work that has been done by our wonderful colleagues here at the Center of Memory and Aging, we have a NeuroWell program. And this NeuroWell program, we have Brain Gym, which basically, it is meant for secondary prevention and preservation of the brain health for those who already had neurological disorder. So a neurologist would refer patient with MCI, Parkinson's disease, mild dementia, and post-stroke to this brain gym. And in this brain gym, there is a multidisciplinary team, exercise physiologists, PT, speech and OT, they work together to maintain cognitive and physical fitness for these patients. The evidence is evolving. We are working on it, and we are planning to kind of extend this secondary prevention executive branch of our brain health clinic to primary. We plan to hopefully to reach out to more diverse audience and get back to the primary prevention as to secondary prevention. That was just like one thing I wanted to share with you that we're thinking about it. In terms of future directions, um, I think what we need to do, and what was the missing point, was that we are in neurology, in at least in vascular neurology, we are really behind cardiologists. So we see what they are doing and then their success. Even in, like, we have preventive cardiology now. I'm thinking about in the neurology. What we need to do is to keep up with the complexity of the brain. Our organ of interest is the most complex, most fascinating creature in the universe, and we cannot address things in a simple way. So we need to keep up with the complexity, and for that, we need to have dedicated brain health. We need to have dedicated brain health experts that spend years and skills on understanding the evidence and helping the individuals at different time point in their life to preserve the brain function. And the other thing is that when we are talking about brain, we are talking about multiple factors. We need to harness the power of the big data. And that brings me to this concept of we need to go away from just a cuff blood pressure measurement. We need to have much more advanced biological sensors that would gather the information. And we need to think about broader spectrum preventive measures, like polypill trials was one of those examples. And again, we need to work on connectome as the network connectivity and kind of a stratification of the resilience in the brain of the people. I would like to wrap up. Sorry that I passed the time a little, but I wanted to kind of mention that brain health is driven with various factors, and you need to kind of make sure that we are addressing them separately. The ABC of brain health is the one that it can be a framework, it's work under progress. And the heart-brain axis, we need to be neurocardiologists and cardiologists and neurologists at the same time. If you are thinking about brain health, we need to be really on top of that. And another thing is that if we need to think about life course. So then we need to be also pediatricians, I guess. We need to really work on the whole spectrum of life course. And at the end, what we need to do, we need to do preventive measures, not to just capture high-risk people, but also to switch the average population. And that means that we need to be more proactive as neurologists in health policy making and moving things towards the middle rather than high-risk group. And at the end, I hope that I kind of made some point that we really need to have brain health experts, not just outsourcing our great responsibilities. Thank you so much for this opportunity. Again, it was a wonderful pleasure for me. And I just wanted to kind of mention that we have this, we passed the Brain Awareness Week, and hopefully every week will be like that.
Thank you, Ben. Maybe if you could stop your screen share so we can let everybody, terrific, because we have quite a big audience. I'm sure there are going to be lots of questions. Please do put your questions in the chat if you'd like, or speak up. I'll try to manage everything that's coming in. Why don't I get started, Ben? First of all, really impressive talk. You've been thinking about this very deeply and studying this for many years, and it shows. I'd love to continue the conversation a little bit about blood pressure, because I think one of our challenges is we as neurologists like to really get into the complexity of the relationship between blood pressure and the brain, and that relationship can be sort of parameterized by how frequently you take the blood pressure, when during the circadian cycle do you take the blood pressure, what outcomes are we interested in? Is brain volume, is it a meaningful outcome to begin with? And I think what I've learned is the quickest way to turn off a primary care physician or a primary care provider, an advanced practice provider, to the brain is by making it more complicated rather than less. And so I wonder whether there's a way to sort of marry both approaches, that of the neurologist. We love complexity, and the brain is obviously very complicated, and the needs of the frontline primary care providers who need very simple instructions about what to do, and frankly, the needs of patients. They need to be told what to do because it's hard enough for them to do it in the first place. So if we if we make it very subtle, I think we undermine ourselves. So I'm wondering how you're thinking about that challenge, that tension.
Absolutely. I mean, there's no other way that we can achieve these without the help of the primary care team. And the primary care physicians and clinicians are really the gateway to assess, do risk stratification, do basic education. They are, I mean, even when I'm seeing stroke patients in the clinic, they are really integral part of our stroke care for secondary prevention. And what I meant is that we need to have something on top of that. We need to have a referral brain health clinic. And that's what takes a lot of education for primary care physicians, but also neurologists to be able to handle that. Yeah, blood pressure is like a nice example, right? So at what point, what blood pressure, what measures would be important? And what I think in an ideal way would be that a close partnership between neurologists and primary care physician. What I have observed in my short career was that we tend to outsource everything to primary care physicians. No, we need to be in a supportive mode, and we need to be on a backup mode and be on a higher level in terms of helping with the brain health, not just say, oh, this is about blood pressure, I don't want to deal with this. No, as a neurologist, I can deal with it. I have the knowledge, and I can be a support to the primary care physician.
Other questions? Feel free to jump in. Otherwise, I will take the next one then. You know, one of the you mentioned the brain gym.
Yeah.
You know, we've thought about that here in Boston, and in fact, at BIDMC, they've had a brain gym for quite a long time. I'm wondering how you're integrating that into your approach. Is that part of research? Is it a clinical paradigm? How do you pay for it? All those questions.
Wonderful question. So Brain Gym and Neuroville program is a paid by service. We have a budget for more vulnerable population, but most of patients will pay for service is about $160 per month. And the way that we are doing it is really work on the progress. So the only trial that, we have like very few trials showing that the multidisciplinary intensive measures would help. And that's our working hypothesis, to work on executive function, to work on the cardiovascular fitness, and that. I think everyone would agree that cardiovascular fitness, intellectual involvement would be beneficial. But that's really also a platform for gathering more data, learning more, and understanding what could be solution for promoting brain health. This is really a combination, and we are very open with our patients that we have this platform, and almost every patient that I refer to, they really love it because it's good for their exercise, good for social engagement, cognitive engagement, and they're happy to pay the cost. For those who would think that they might be a little bit on a lower socioeconomic status, we would provide it for free. But this is really an evolving platform for us, and we are learning from it.
Ahmed, do you want to ask a question, or would you like me to read it?
I see a question in the spot.
Thank you so much for inviting me to this wonderful lecture. I've always had the question as to whether or not there have been any brain imaging studies to demonstrate in a randomized clinical trial basis that interventions improve any of the morphological measures that we often refer to as indicators of brain health. There are a lot of fascinating cross-sectional data, but are you aware of any prospective randomized trials that show efficacy?
Right, Sprint Mind, the one that I shared with you, that's probably the only study, but also we have finished a study, Finger trial, that shows that intensive work on executive function, intensive work on the risk factor management would lead to improvement of the cognitive function. And a sprint one is the one that actually showing that even over 3 years, we always think about the long prodromal phase, even over 3 to 4 years of intervention with lowering blood pressure in intensive way in a specific population. So patients with a stroke and diabetes were, for example, excluded. They actually, as I shared with you, show that you can decrease the burden of white matter disease, you can improve the hippocampus volume, and again, the really recent thing is that you can improve the cerebral blood flow. And there are some, as you said, there are some smaller scale studies showing that. But let me share with you something that we are really looking at really gross things. As Dr. Rosen mentioned, is that total brain volume or just even hippocampus volume is a good outcome measure for us. Probably in advancing our knowledge, we would see that we can actually see subtle changes in the improvement of the network connectivity. That's what I'm most looking forward in terms of the structural improvement in the future.
Excellent point. Thank you so much.
We have a question from Sarah. Would you like to speak it yourself?
Sure. I have a question about like how good our outcome measurement tools are. And again, like the neurologic disease is so wide and broad, but in your opinion, like, is there a need for a better, more specific functional measurement of how someone is functioning in their life? Are the cognitive batteries that we have, and there are so many, practical for use and also specific enough to detect whether we're bending that curve earlier? Are radiographic surrogates good in terms of white matter burden? And to the earlier question, like, should we even be paying attention to brain morphology if we know that there are these discrepancies between pathologic burden and someone's actual cognitive reserve, or cognitive function?
I mean, wonderful question. I think everyone would agree that we are now working, because the mindset behind our practice was to diagnose a disease, not subtle changes, not the small stresses that's in the brain. I think already we have very good cognitive data, and I think, as I shared with you, in all those slides that I shared with you, we were looking at people who did not have dementia or MCI, and still you could see that, for example, response to a stroke test or immediate memory test. I think what we have, of course, there's always this issue of harmonization. Personally, I really like the NIH toolbox as a sensitive measure, especially for vascular components. I think in terms of cognitive function, we are doing fine because it can pick up subtle changes. But when it comes to gross morphological changes, as I shared, I think we need to dive deeper. We need to look at more early changes. DTI at some point, I think, was very promising tool, although I think we have now even more subtle changes in the connectome that we need to work on it. I think in terms of cognitive function, I feel comfortable, but in terms of morphological changes or even biomarkers, I think there's a long road to go through, specifically if you are thinking about life course, if you are thinking about early young adult.
That's a question.
I hope I answered the question.
Another question from a cardiologist. You mentioned BNP and other aspects related to flow, for example. I wonder what your thoughts are in terms of the impact of inflammation and controlling inflammation through some of the strategies that you mentioned. How much is inflammation playing a role in what you're seeing?
Absolutely. So I did not want to get into details of that because, when it comes, so three major measures are very important for brain health. One would be cardiac function and heart-brain axis integrity. The other would be exercise, and the other thing would be sleep. So, and as you know, almost all these new SNPs that have been detected recently for dementia and cognitive health, they have something to do with the immune system and inflammation. But what I'm what I'm most interested in, and I might have mentioned it in my talk, is that we need to really look at the upstream, not the downstream pathway. So, for example, there were some thoughts at some point that maybe NSAIDs would help, but it's really down the pathway intervention. The way that I see that, and again, it could be just because I'm trying to kind of have a broad view on that, is that we need to do interventions like exercise that we know that is known to decrease the systemic inflammation, sleep hygiene, and all those cardiovascular interventions early life to decrease the inflammation. But I see inflammation more down the pathway, not necessarily a target that we need to pharmacologically address that. At least so far, the data is not showing that if you just bring down interleukin-6, bring down TNF-alpha, that would have an immediate translation for brain health.
Thank you.
Now, if there are no further questions, I want to thank Dr. Sabayan very much. It's great to see you, Ben. Looking forward to many more conversations and having you back here to present in the future.
Thank you so much for the opportunity.